Hey, students, we're going to jump into special populations. This is, I believe, 3 chapters in your book, maybe 4. But we're going to dive right in. All right. So you're going to get a lot of information on this chapter. There's a lot of stuff from the book I put directly in, a lot of charts and things like that. It would be good to know the specifics. I know it's going to seem like a lot, but again, for the test, especially for people that don't work with special populations, this might be a place where you need to study a little bit more, right? Some of us are really good with program design. Some of us are really good with the physiological side, and then just working with specific populations. According to the NSCA, that might be where we need to review a little bit. So just be aware of that as we're kind of going through these things. So who's considered specialized? Those who are older or frail, pre-adolescent or adolescents, pregnant or recently given birth, overweight/obese, eating orthopedic or arthritic disorders, post-cardiac events, and are in rehab. So if they're rehabilitating, respiratory conditions, maybe something such as asthma, those working in a specific sport, right, or competition, and then those that suffer from things like back pain, cancer, epilepsy, MS, CP, or metabolic syndrome. So basically, a lot of people that are going on, or just, I will call it, struggling through life, or if you're in a sport, then you are specialized for your sport, right? So this would move us slightly outside of what we would call like the general population, right? The relatively healthy sort of scale. So we're going to kind of address a lot of these, and hopefully it'll make sense on where some of the little bit of changes come from. Pre-adolescent and adolescent. Okay, so working with kids, essentially. Making sure there's adult supervision and instruction, right? Don't be alone with youth, typically. Create a safe training environment, include a dynamic warm-up for these kids. Then they give you sets and rep ranges. Now, again, this is the NSCA's guidelines, so they might ask you on the exam, what is the typical repetitions for pre-adolescent, children in exercises, things like that. They also recommend full body exercises, right? Resistance training, maybe 2 to 3 days a week, and then, and then non-consecutive. So don't do like a Monday, Tuesday, or a Wednesday, Thursday. Space them out, okay? And that doesn't have to be crazy resistance training, okay? You can do full body calisthenics as well, and that should be more than enough for a lot of them. Teaching some type of cool down or implementing a cool down process, and then varying the program, right? We talked about, and you're working on those workout cards. Those workout cards are in those 4-week blocks. You might need to vary it even more with kids to keep it entertaining, keep them engaged, things like that. Personal trainers who train children, okay? So design activities that ensure equal participation and enjoyment, almost like, this is gonna sound maybe counterintuitive, but almost like physical education teachers, right? How they need to keep everyone engaged. You can't have people just waiting on the sidelines the whole time, those who avoid activity. How do we make it fun, right? And you can even do this with your adults as well. Making it fun, making it competitive, typically works really well. Gradually progress, again, progressing the exercises. Focus on skill improvement, offer a variety, right? Less regimented, right? They're going to be free flowing. They may not be great at it. They may be really good at it, just depending on where their development's at. And then again, hydration and that sort of stuff is going to be vitally important. Older adults. So now we're going to kind of start splitting into aerobic and then resistance training. So with the aerobic, increased caloric utilization, right? We're going to hopefully reduce body weight, lessen the risk of high blood pressure, type 2 diabetes, obesity, stroke, osteoporosis, and some cancers. Now, again, this is a part of the equation. I think nutrition, as we talked about before, is another huge component of it. If you think just cardio on the treadmill is going to do it, we've seen people on the treadmills. It's not always the case. Okay. Yes, resistance training is going to be important, but your diet's going to be important as well. Resistance training, reducing cardiovascular disease. So decreasing that resting blood pressure, right? So bringing it down so they're not always so high. Blood lipid profile would be things like cholesterol, and then enhancing vascular conditions. So your blood flow, making that blood flow better. What gets reduced? Again, colon cancer, diabetes, osteoporosis, low back pain, hopefully, arthritis, depression, and muscle loss, right? I did something recently in a lecture in one of my courses, talking about the amount of muscle we keep can be a good determinant of our longevity. The more muscle mass you have, that's going to keep your metabolic rate high because muscle is more demanding. So that's going to increase your caloric burning, which is going to, right? Then we're going to play that calorie game. So it's going to keep our weight hopefully manageable as long as our diet is kind of in place. So resistance training can be huge to keep that muscle, build that muscle, and then aerobic, obviously healthy for the heart and the cardiovascular system as well. Some guidelines. Okay, again, these are the important components to not forget when asked, if asked on an exam. So again, 2 to 3 days a week, you can use single and multi-joint exercises. So again, think like bicep curl, right, would be a single joint, or like a squat or something like that could be your multi-joint. Controlled exercise speeds. So again, don't just have them collapse into exercises, right? You can add a tempo to it, and things like that. And then through their range of motion. Now, it might not be huge, but again, going through their range of motion, not forcing them into positions they don't know how to get to or get through properly. Start with light loads, right? Many repetitions. So we talked about that in the programming, right? If the intensity is really low, then you can have the repetitions a lot higher, the volume, right? And as you increase the intensity, the repetitions and the volume has to come down. But again, may increase up to 90%, right? But start light and build your way up. Competent instruction, again, a lot of that's going to be modeling, talking them through, developing coaching cues, right, is going to be really important as well. And then obviously watching them is going to be huge. You can't just wander off. Aerobic, again, 2 to 5 days a week. So you can do it more often. You typically don't have to go as long. Again, for them, 20 minutes might be good. A progression might be increasing the amount of time. 60 to 90%, but you can start as low as 40, depending on where they're at, right? Just age is just a component. They could be fit in their older age. They might be very unfit. They might never have exercised. Okay. So it's finding their range. But again, that comes from learning about your client, doing those assessments. Exercise order, this is recommended. So again, the aerobic activity first, then resistance training, and then concluding with some static stretches. Static stretching is holding a position. A lot of us have done this probably before exercise, but like if I'm going to do one across my body, right, you would hold for 30 seconds or 20 seconds, right? Not a lot of movement going on, and then coming back. That's going to help lengthening the tissue and things. For pregnant women, benefits. So it is beneficial to exercise while pregnant, okay? Improved cardiorespiratory and muscular fitness. Again, keeping that muscle on, keeping your heart healthy. Recovery from labor. So you're kind of not preventing labor, but you're building yourself up. So then labor is going to happen, a hugely high stress event. And we've talked about that stress. So preparing our body for that, and then having something kind of on the back end of that as we recover. A faster return to pre-pregnancy weight, more energy reserve, right? Less weight gain. Again, some weight gain is obviously, one, it's important because you need, the baby is going to be growing and then also feeding the baby. But you also don't want to become obese because of it. So there's a balance. Reduce feelings of stress, anxiety, and depression. We've talked about that hugely in the psychology side, even talking about like postpartum depression, things of that nature, right? Exercise being a huge benefit to those things. And then a reduced risk of preeclampsia, right? So that high blood pressure because of being pregnant. So you can reduce those risks, which is going to be hugely beneficial. Exercising, performing at least 15 minutes of moderate intensity exercise per day. You can increase up to 30 minutes. So again, it doesn't take a lot, just some movement in there, right? Multiple repetitions in resistance training. So probably not testing your 1RM while you're pregnant, right? Don't test your max squat while you're pregnant. The pressure you're going to build up, right, is going to be different. Isometric exercises, those are the ones that don't move, right? So things like planks may not be the most ideal, right? Those holds, or if you're under, you know, a rack or anything like that, where you're pushing into nothing and you're not, or into something and you're not moving. Again, things to avoid. Exercises in the supine position after the first trimester. I remember that was on my exam. I know it's been a while, but just what exercises to avoid. Do not continue past point of fatigue and never reach exhaustion, right? We never want to get to the point of like passing out, falling over, that sort of thing. You can get an exercise in that is beneficial without getting to the point of feeling like you're going to die. Avoid activities that may cause abdominal trauma, right? I don't need to do, we used to do this thing to kind of build our core where we would be, not to the point of full pain, but like engagement of the core. So actually getting hit in the stomach, obviously not a good idea for someone who's pregnant. And then again, you're hydrating accordingly. You're looking at your sodium intakes and things like that. Overweight and obese. So real quick, what defines those is what pretty universally, or at least in the US, is looking at what's called BMI. So that is your waist to weight ratio, or waist height and weight ratio. So BMI of 25 to 29.9, and they use kilograms, that's considered overweight. Anything 30 and above is considered obese. Now, this is if you do no exercising, it can be a decent tool. If you have any type of muscle mass on you, this is where the BMI comes a little skewed. I would be almost considered overweight, just because of the muscle mass that I have in accordance with my size. So just be aware of that. But again, you can see people, a lot of them are going to be clearly overweight or obese. And so here's, again, a chart from your book that just shows that normal weight and waist circumference looks. So obese, again, you have underweight on the left, and then working down to extreme obesity over 40. Again, you can see, so this is your waist circumference, right, as you're going through. So just being aware of those numbers. Okay, so just knowing kind of where they're at. So you might get it might describe a client, and they might ask you, what level of overweight or obese are these people? And it is, I know it's a lot of numbers, but it's knowing those numbers and knowing those ranges. Obesity causes. Now this is again the NSCA. I've been doing a lot of my own kind of research and readings on it, and we can talk about that, or I'll touch on that. But again, for the book's sake, genetic, metabolic, behavioral, environmental, cultural, and socioeconomic so there's a lot of moving pieces to it. The one that they don't really include in here, I guess it kind of falls into behavioral, is going to be connected to diet. And what I would tie a lot of that directly towards, for the majority of people, is excess processed foods and excess carbohydrate consumption. Because what also is tied to that is something called insulin resistance, where fat stores, you're in a storing mode a lot of the time. Again, I'm not trying to get controversial, but it's just, this seems to be more where the research is going, not so much what's been taught by the mainstream areas of study. So these are components for sure, but just be aware of those things. Behavioral and environment. It's not just the person's will. The person didn't will themselves to be obese. A lot of people try to undereat, and they still become overweight or obese because their body actually shuts down more. So it slows down their metabolic rate, so they don't burn as many calories, even though they decrease their eating. So again, there's a lot of different factors. I'll try to leave it there. But just, if you want to talk more about it, again, send me an email or send me a message. Exercise benefits. Exercise benefits in a weight loss program. So what are the benefits, right? What is the point of exercise? Now, again, it's not just move more, eat less that's going to lead to weight loss, okay? But this is some of the things that it can do. It increases your energy expenditure, right? You might burn an extra 300, 500 calories a day. Now, if you're replenishing that, then you get a net zero. But again, you have increased energy expenditure. If you went from zero exercise to this, that's a pretty big gap you can create. Again, reducing your risk of heart disease, increasing the strength of your heart and of your blood vessels, reducing your body fat. Again, I would say almost more important is preventing the decrease of muscle. Keeping that muscle around is going to keep your metabolic rate high. Sometimes you can access your body fat storage. Again, depends on what you're consuming and when you're consuming it. Decreased abdominal fat. Again, it's access to that energy source. Fat is an energy source. Decreasing insulin resistance. We just kind of talked about this. Insulin is a storage molecule. When you exercise, your body wants to use that up, especially like blood glucose and things like, or glucose and things like that. So it's going to be a different response. Better dietary compliance, right? Hopefully tied with exercise. You're not just eating whatever you want. and there might be a reduced caloric intake. Again, I'm more on the side of food satiety, so feeling full rather than feeling hungry, even if it's reduced calories. Again, something to talk about kind of on the side if you'd like. Improve mood. We talked about this in the psychology chapter, right? The mood enhancement that you get, general well-being, the sense of accomplishment, potentially an improved body image, right? Which can lead to positive mentalities and things like that. Self-esteem, right? You're looking better, you're feeling better, you're doing more things, you're proud of yourself. Again, you're building these up, this psychological benefit. And serves as a coping strategy. Now, people can be addicted to exercise just like they can be addicted to food or to drugs or alcohol or something like that. Now, does it seem to be the more healthy option? Sure. But just because you're addicted to exercise doesn't make it healthy mentally, right? But it can be a better coping strategy than, say, binge eating or laziness or, any other addiction that you're kind of going through. I believe this is in your book. So you have exercise on the left, and then you've got kind of weight control on the far right over here. And so we are looking at the first two, you're looking at physiological mechanisms and psychological mechanisms. So how do these all help with weight control from a physiological, from a body standpoint, right? Caloric expenditure increases, your appetite might be affected, what you're choosing to eat, that's your macronutrients, right? So proteins, carbs, and fats, keeping your lean body mass, so keeping your muscle, and then prevention of decline in resting metabolic rate, right? We don't want that resting metabolic rate to go down. We actually want to keep that high so the calories continue to burn. From the psychological side, again, mood, well-being are going to increase. Body image is going to, feeling of body image, self-efficacy, self-esteem, those increase, right? Motivation, commitment, you start seeing those results, right? That's why results are important. And for us as personal trainers to point them out to our clients, right? You see those results, you might continue to comply with whatever's going on. You keep improving on your exercise. You push yourself, right? We progress. You continue to challenge yourself. And all of that can kind of play a role in that weight control, okay? And develop. Now, weight isn't the end all be all. If you're already kind of lean, we'll keep it at that, right? But you do have some body fat you want to lose. You might not lose any weight, but what you might lose is body fat percentage, right? So if I increase my muscle mass and I decrease my body fat, I might stay at the same weight or close to it, but look at what the body fat percentage is. Have the person look at themselves in the mirror. Do they look different? Do they feel different? Do they look leaner, more toned? Do they start to see muscle definition? They might still weigh the same, but that's an improvement on their bodies. Okay, so that's another thing you can explain to your clients as well. Overweight exercise concerns. So again, heat tolerance isn't one. Movement restriction. They might not be able to move as well. One I had to learn pretty early on was them getting up and down off the floor, right? Especially if you're doing things like, not that you'd be doing burpees, but things like sit-ups, and then you're going to do squats. So it's a lot of getting up and getting down. They either need help, they might be kind of ashamed of having to do that. So think about ways you can either keep them up the entire time or do a lot of work on the ground, okay? So that they're not bouncing up and down, trying to get up off the ground and down, and they're using that time, or it's going to be some cause of issue for them. Weight-bearing stress. How much can they weight? Think about support, right? You can think about like TRX straps, right? Something they can hold on to. Even holding a wall or using a box to get up and down off the ground, things like that. They might have posture problems, low back pain, balance issues. They may have not moved very much. Hypernia or dyspnea. So again, just things to be aware of with your overweight or obese clients. Now, this is in your book. Again, it looks like a lot, but again, hopefully we're building on everything we've been looking at. So again, you have aerobic training, which we've been looking at, resistance training, and then they even throw in some flexibility training here. So frequency, intensity, duration, that's programming. We just looked at programming. So hopefully you'll see those numbers and it won't look overwhelming. You'll understand a lot of it. And then guidelines and concerns regarding those things, right? Using low impact activities. So jumps or box jumps, you're trying those things, jumping off of something, probably not the best idea when they're not capable of doing it yet, okay? Resistance training, they can begin with body weight exercises, right? If you're overweight or obese, that's a lot of body weight to move, and that can be good. Just being aware of the amount of training that they're doing, the number of repetitions, right? Where you might need to start with 2 sets and then progress to 3 and maybe 4 sets. things like that. So look over this. Again, it is in your book, or you can pause this and take a look at it. Diabetes. There are two types, type 1 insulin dependent, and then absolute insulin deficiency. So this is one typically you're born with or you develop very early on, where your body doesn't create insulin. Okay. The one that's more, I don't want to say in control, causal is type 2. This is where it's non-insulin dependent. This is the insulin resistance. So short version of what happens, sugars in your blood, insulin gets released to help bring that glucose into the cells. But if you continue to eat things like high processed foods or high sugars, or you eat consistently, and I know we've been told to eat 6 meals a day, a lot of us, especially in the fitness world, right? You want to eat 6 meals to keep your metabolic rate up. What that can also do, especially if you're not exercising, is keep that insulin really high, because you keep feeding your system, you keep feeding it sugar. And so the body goes, oh, I need to, release more insulin, release more insulin, release more insulin. The more insulin you release, the more resistant your cells get to receiving that insulin and the response. What your body does then is it pumps more insulin into the system, which makes the cells even more resistant. And then you have this really bad cycle, okay, where insulin continues to get pumped, the cells continue to fight against it, and the insulin continues to go. So all that, it's still storing, and there's just no way to, well, not no way to decrease it, but if you continue to eat that way and live that lifestyle, that's not going to stop, okay? Real short, what I would say to those that either know people with diabetes, type 2 diabetes, or are struggling with diabetes, extended times of not feeding, okay? Fasting, intermittent fasting is really popular right now. Time restricted feeding is going to help that insulin decrease, okay? And then I would also say lower carbohydrate consumption is definitely going to cause your insulin to decrease, okay? So those are what my 2 general recommendations. Again, I'm not a doctor, so don't follow them to the T, but just in general, or if you want to explore more of that, I can give you resources. Exercise prescription, again, the benefits, right? You increase your insulin sensitivity and glucose utilization. Glucose, again, is our sugar utilization. If you're going to exercise, your muscles are going to use it. So now your glucose is being utilized. Okay. That's a good thing. And it also helps with that insulin sensitivity, right? We're helping reverse that insulin resistance. Be careful of hypoglycemia. That's low blood sugar. Again, if you're increasing your exercise intensity, you work out for a long time, especially if you're not used to it. You don't eat enough, right? And you take too much insulin, right? So a lot of insulin is going to pull a lot of sugar into the cells, which means it's not going to be in your blood, which is hypoglycemia. So just being mindful of that, listening to your clients and those types of things. Okay. Again, aerobic resistance and flexibility training. Take a look at these and then compare them to obesity and overweight. They might be a little bit different. Some of it might be crossover, right? Because if you're typically overweight and obese, you might also be type 2 diabetic. Okay. So just be aware of that. But again, look at these. They're in your book and just be mindful of them. So cardiovascular and respiratory conditions. So hypertension would be one, okay? This is your blood pressure, so your systolic or your diastolic is at those levels or above, okay? And you have this really nice chart in your book looking at those pressures. Again, systolic and diastolic. You're normal here, you're pre-hyper here, stage 2, and it's going to tell you, again, your initial drug therapy. So it's giving you the ranges, right, to prepare you for that. Now, again, you're not a doctor, you're not performing these tests. You can't, a lot of personal trainers have the ability to, whether they've been in the medical field or they studied it in school and things like that. But again, recommend going to your doctor or your clients going to the doctor to get this information. Safety considerations, okay? Keeping the intensity, the maximal oxygen, so that VO2 max that we talked way back, I think it was chapter 2. You don't want to go too high, okay? Just because of those cardiovascular issues, okay? Or respiratory issues. Prolonged Valsalva maneuvers, that's the one with the breathing and bracing. So, and then you brace and you generate this tension in the core. Again, good for core development, but that's also going to increase the pressure in the heart rate, okay? So you can't do I would recommend not doing too much of that. Okay. And then again, safe exercises for the individual. So make sure you are not just a cookie cutter program. Okay. Make sure that it is something beneficial to the client and not going to injure them, hopefully. Hypertension guidelines. Again, you have aerobic and resistance training guidelines. So aerobically, 40 to 50% of the VO2, we just talked about that, working up to maybe 50, and then maybe even up to 85, okay? 15 to 30 minutes, again, starting small, working up to 60, and then again, starting at 3 days maybe, and then going up to 7. Resistance training, again, we talked about that 1 RM. We're staying away from it. So you wouldn't do a 1 RM test because that's going to be 100, right? You might have to use a multi-rep test to get to that one or estimated 1 rep max, and then 50 to 60% of that. Full recovery for these individuals. We're not trying to do HIIT training with them or anything like that. High intensity training. Allow that full recovery. Again, maybe only 1 to 3 sets. Large muscle multi-joint movements. That could be a body weight squat, push-ups or some variation of a press. Again, use different movement classifications. And then eventually, maybe you can decrease to 8 to 12 reps, right? So we're thinking very high repetitions to start because the intensity is so much lower. Maybe you can increase your frequency of days, and then also your duration could progress. But again, start easy. What looks easy, again, isn't easy for them, and then progress through the rest of the exercises. Myocardial infarction, strokes, and pulmonary. Excuse me. So for myocardial, again, heart issues, make sure they're cleared by a doctor, right? Go to the doctor. That'll provide them with the intensity level they're allowed to do and what's called the MET level. That's a lot of times that's tied to exercises or things at home like gardening, going upstairs, getting up and down off the ground, things like that. Again, and then when you write your program, give it back to the client and have them bring it to their doctor so the doctor can approve it. Great. Covering yourself to protect the individual. Continue to monitor abnormal signs. Okay. Chest pain, shortness of breath, nausea, neck pain. If you don't have those, sometimes we just think, oh, I'm tired or I worked hard. It could be something really critical for someone with this condition. Okay. So don't just brush it off. Don't say push through it. You're going to have to be a little more aware. It's a little more work on our end. Intensity, starting low, right? 40% of your VO2 max. Start low on the total time scale, 15 to 40 minutes, 3 to 4 days a week. Again, higher repetitions, way lower intensity. As we're going through, start with 2 to 3, and then maybe build up to that 3 to 4. For stroke, okay, specifically with aerobic, so they probably after a stroke did some type of rehabilitation, whether that was outpatient with their doctor, something like that. Start there. Okay. Don't jump into 85%, right? They might be at 4%. They might just be at walking. You might walk around the gym with them, right? We don't know. Use ergonometers, excuse me. Again, if you need to, that could be like a seated bike. That could be a elliptical machine, right? Something that whatever's limited in their abilities. Again, it might only be 5 minutes to start and then work up to an hour. Again, 3 times a week. So again, you have to be more mindful of those types of things. Resistance training, right? Because of what happens with the stroke, where usually one side of the body loses the ability to move, and maybe it'll naturally come back. We need to develop some new neural pathways. We talked about this early on, that a lot of the initial gains in muscle in resistance training are neurological, right? Because the nerves are sending signals to the muscle, right? Whether that's rate coding or the number of motor units being recruited. So what you can do actually is, if there's, and what crossover effect is really cool. So let's say I lost the ability to move on my left side. This is my left side. I know it's mirrored. What if you train the right side? So if I train my right arm or my right leg, it will have a benefit on my left arm or my left leg. Okay. Maybe not to the same extent, but my body is going to try to do that. And then you try to implement what you can with the side that's weakened or unable to move. Okay. Eventually, again, you're striving for 3 sets of 8 to 12 reps and then 2 to 3 days a week. You don't just start there. You can include some flexibility training. Again, you don't want this person to just think of a bundled rubber band, right? Continue to keep the person moving as best as you can. And then even coordination and balance, right? Single leg balance, maybe even, so instead of single leg, maybe you go staggered stance. So one in front of the other, right? That's going to be different. Space it out. Whatever you can do, right, to develop that coordination. Peripheral vascular disease, the PVD, again, increase the length of person's activity time to improve their quality of life. That is the goal here. Again, be cleared by a doctor. Okay. Aerobic training, walking greater distances pain-free. So one thing that happens is people start to hurt, right? So you walk until it hurts, don't necessarily push through that. But again, you're pushing that needle or moving that wall a little bit more as you go. Resistance training. Again, a lot of these are going to seem similar. 3 to 4 days a week, 1 to 3 sets, 20 reps, 2 to 3 days a week. You notice there's a lot of crossover. So it's, if you can understand kind of the general, you're probably, even if you have to guess correctly, they're not too crazy. It's not like myocardial infarction's 3 repetitions and then PVD is 20. They're all in that higher rep range to start. And then we build up to higher intensities and less repetitions. Asthma. Okay, some guidelines with asthma. Monitoring RPE is rate of perceived exertion, so how hard the individual thinks they're working, and then shortness of breath, that really quick breathing. If they feel like a burning in their chest or like a cackling or a wheezing, right? So being aware of those things. Try to stay out of temperature extremes, again, really hot, really cold. Aerobic, large muscle aerobic activity helps improve that VO2 max, which is what we're trying to do. RPE 11 to 13 out of 20. So it's like that middle range. So in a 0 to 10 or 1 to 10, that'd be about a 5. Okay. So we're not pushing it to where they think they're going to die, but it's also not so easy. They're not gaining anything. It's somewhere in the middle. Again, 1 to 2 times daily, maybe 3 to 7 times a week, and then 30 minutes a session. With resistance training, increase the maximal number of repetitions, amount of training volume. So again, you may not cure their asthma, but despite their asthma, you're going to allow the body to push more and more and make the body more efficient. Okay. Start with lighter loads, like we've been talking about, more repetitions, building those things up. Rehabilitation concerns. Okay. So we have so we're talking about rehab. So someone might come to you with either macro trauma or micro trauma. Again, the real difference. Macro is big, micro is small. Injury with sudden tissue overload and damage. This is acute. Micro would be chronic kind of issues. Okay. This might be training errors, faulty biomechanics. Some might be genetic. So there's a difference between those. Okay. Some examples, a contusion. So that'd be like a bone bruise. Okay. A strain is like a muscle pull, and that could be a muscle tear depending on the severity. Tendinopathy, an ankle sprain, bursitis is swelling. Okay. So those are just some examples. Here's a more detailed look at them. Again, this is in your book. You can take a look at. Okay. Joint dislocation is another one. Osteoarthritis, a fracture, a stress fracture. Okay. Those types of things. What the injury might do, right? And if you've ever been injured, you've experienced this. Limited range of motion, right? If I do something to my shoulder, I may not be able to move it in certain directions, right? I may not be able to go overhead. So don't put someone overhead if they can't get there, okay? It might be really weak, right? If I haven't used it for a while, it might be unbalanced. Maybe it's a knee or an ankle issue and I can't stand on it very well. Coordinated movements might be out of whack, okay? These are just things to be aware of. So you can't just jump back in 0 to 60. Okay. The psychological effects, another thing again to be aware of. They might be very impatient as a client, especially if they're an athlete, right? They might get very angry, frustrated. They might be fearful, right? A lot of times you see injuries, especially if it's like something like an ACL tear, which is in your knee, and it was on a cut. The athlete or the individual might be really afraid of making a cut again, right? Because they're like, well, last time I cut my knee popped. So how am I going to feel better now? So it's developed. So you just got to be aware of these things as you're bringing the person back into full function. Again, they might also have deficits in neuromuscular control and balance, right? Awareness. If you don't use your leg for 9 months, it's gonna be real hard to just jump back in. Your brain and your neurons have to relearn and be reintroduced. Low back pain is a big one. I know it's a catch-all term, and it's something like 60% of people in America struggle with low back pain, but that's a really general term. It could be a disc issue. It could be a muscle issue. It could be a lumbar spinal issue. Okay. This can be acute or chronic. It might happen over a long stretch of time, something that I've had to deal with, or it can be acute. It might be a car accident. It might be they twisted the wrong way. They tried to lift something, a box in their house or something like that. What does this respond well to? In general, Again, spinal stabilization, posture. We can talk about posture. We will talk about posture really quick. There is no perfect posture. If you told me like sitting back and up and all this is perfect, you don't live life that way, right? We don't live in this world all the time where everything I do is here. I need to be able to bend and lean and twist. And so I would say that posture, bad posture, is any posture you're stuck in, right? So some of us are, yes, postured into this like rounded position, right? But some of us are also stuck in what's called extended position, like I am. And I have to continually fight that to get back into better being in a bent position. So just know that as we're kind of going, you want the spine to move, but you also want it to stabilize. So there's kind of an if and with that, or both and. Here's something that has been challenged in my mind recently, but I do want to bring it up to you because it might be something to help address. So this is called cross syndrome. This one would specifically be lower cross syndrome. So if you look at it, you see this X, and you have weak on one side and tight on the other of each end of the X. So in general, people have tight hip flexors. Okay, tight typically can be short or it can be long. Okay, it doesn't all mean short. Okay, and then you also have tight erector spinae. That's your low back muscles. Okay, then you have weak abdominal muscles and weak glute max muscles. So because they're weak, you don't use them. And so what happens is the ilio and its function and the erectors and their function, you might get this really big extended position, really big lumbar bend in your spine. So this might be really deep here. Okay. And then this is shortened typically as well. And then you'll see this kind of stick out. You'll see the rib cage kind of flare, right? So instead of being down, it might be opened up. And then the butt actually might stick out a little bit more because you're not engaging those hip extenders, okay? Another thing, I'll show you the upper body in a second, is this joint by joint approach. Now, again, I just told you that all joints should move within their range of motion, but some seem to be more mobile and some seem to be more stable. Now, the stable ones definitely still need to move, okay? So I'm not saying that they only one or the other, okay? But we do have this natural desire, maybe you've never thought about this before, where our body alternates between mobile joints and stable joints, right? So if we can start at the bottom here, right? The ankle's pretty mobile if you think about it, or it should be, right? The things we can do with moving our foot, okay? Then the knee is a pretty stable. Now it still moves, right? But it's pretty stable. Now, the challenge would be you can actually work on that knee joint to actually do a little bit of this rotation, tibial rotation, okay? It's not going to be as great as your shoulder, but again, the main movement's here, but again, working on that rotation. Then you get to the hip. Hip is very mobile, right? You think about ball and socket, right? All that movement we have. Then we get to the spine, the lumbar spine, typically stable, but if you've ever done like a cat-cow exercise, those do bend, right? They do. If I hunch over, my lumbar flexed, just like it can extend. So it does move, okay? And you can actually rotate it very little, right? There's a little bit of rotation in those vertebrae, but it does help with stabilization, core stabilization. Then you get your T-spine, your thoracic spine. That's even more mobile, right? If we think about all the movement that does compared to the lumbar. Shoulder tends to be, it's again, considered stable, but we also want that shoulder blade to move a lot. If I raise this arm overhead, I want this shoulder blade to move. If it doesn't move, I'm going to compensate at some other joint and we're going to get shoulder pain potentially. Okay. Then you get to the humerus, again, shoulder, a lot of movement there. Elbow, similar to the knee, you get some movement, but you can also get, I guess I can show it here, right? At the elbow, I get a little bit of rotation, right? So you get both, but just being aware, it's mainly stable. And then you get your wrist, which does all kinds of movements, right? So on and so forth. So that's the joint by joint approach. Just some educational. This isn't in the book, I believe, but I wanted to give you just that introduction to it. If you want to look at it more, there's YouTube videos on it. Gray Cook and Mike Boyle kind of reintroduced it or introduced it. Some low back stuff, again, so lumbar flexion, rotation. If you got a muscle strain, again, they're going to look at contraindications. Those are things not to do, right? So they would say if you have pain with lumbar flexion, so think that bending over, Probably not a great idea to do sit-ups where you're bent over going into that pain, right? I'm a big person of avoiding pain, but still working through whatever you can. Okay. Not just passiveness and not doing anything. Okay. So be aware of the individual, what causes the pain. It's not always the same for everybody. So again, you can't do a cookie cutter program. Okay. Just be aware of that. Here's upper cross for the shoulder, or for the upper body, excuse me. So what tends to be weak are the deep neck flexors and then the lower trap. So the lower trap is on your back. That's what helps with that shoulder or shoulder blade rotation that I just talked about. What seems to be tight, upper trap. So a lot of us tend to live up here, okay? And then tight pecs. So if I can go sideways real quick. So here, and then internally rotated, okay? Tight pecs. So that's why a lot of people say we need to work our back and pull our shoulders down and back. Again, you don't want to be locked in a position. You should be able to move into any of those positions, okay? So if we strengthen our lower trap, so activate it, right? Use it more often, and then working on our neck position so we're not always head forward, right? Learning how to bring it back, and relaxing our traps a little bit more, right? Just something to maybe look at as we go. Shoulder impingement, okay, so a pinching. So you get this pinching sensation, again, of the supraspinatus muscle. Sorry, right here. Maybe the bicep tendon, right? So the bicep tendon runs all the way up into the shoulder, and then the subacromial bursa. So you kind of get this like meeting point right here where there's actually not a ton of space. And so you might get some issue there. Again, what can fix it or potentially correct it? Posture. Again, we think this is bad. It's just, if I can't move into other positions, then it becomes bad. Okay. Scapular control. We just talked about that. So not only can it stabilize, but can it rotate, right? Does it stay on the rib cage? Does it glide around the rib cage? Okay, is another one. You can reduce the use of overhead movements again, but if you avoid overhead forever, you will never be able to get back to overhead, right? The body adapts to what it is stressed in. So how do I work? Maybe it's only out in front first, and then I work up a little higher, a little bit higher, a little bit higher, and then I've generated the tissue to get there, okay? Again, these are some exercises. I believe these are in your book. Again, this is more, looks like external rotation for a lot of these. But again, just some exercise. Don't implement them unless you know why you're doing it or how to do it, okay, and what it's doing. Don't just do it because it's in the book. Again, some shoulder movements, impingement syndrome, shoulder instability. So maybe they don't have that stability, okay? Rotator cuff issues. Maybe you're working with baseball players or an athlete, overhead athlete, right? Just things to be aware of that might be contraindicated. Now, again, it doesn't mean never do these. It just might, maybe don't start with these. You got to turn on the brain, right? Create exercises that are going to be beneficial, still create the goal, right? Maybe the goal is I want to be able to lift overhead, but I have shoulder issues. Are you just going to say, I can't do it? Or are you going to go, okay, how do I progress this so we can get back to that? Okay. It takes a lot more thinking than maybe you thought before you jumped into personal training. Ankle, one of the most common sports related injuries. Okay. Most frequent is inversion. So the ankles here and then rotating outward, right? You watch this with basketball players all the time where they land on each other. So you get some lateral ligament injury. Okay. So just being aware of things to be, so maybe not loading them full weight bearing, right? Maybe introducing some light weight bearing stuff as you go through. Open chain exercises, that means the foot's not planted on the ground, right? So that takes the pressure off of the ankle as you're doing strength training exercises. Because again, we don't, just because you roll your ankle doesn't mean, oh, I can't do any lower body exercise. I've just got to do upper body the whole time. It's like, no, you can still build muscle, but maybe not have the foot on the ground. The knee, you might get some front knee pain, anterior is front. So runner's knee, might be an ACL injury. So again, that's the anterior collateral ligament. Or if they've done like a knee replacement or anything like that. Again, those are just some common ones to be aware of. Again, still in your book, things to be aware of. Again, we're trying to avoid pain, but eventually get back to full function, whatever full function is. And that's the end. Okay, so I know that touched on a lot of them. Maybe not on athletic population specifically, but that is in your book if you want to take a look at it. I'm more worried about the special populations, more so suffering from detrimental things. But again, hopefully you're still working through your assignments and everything like that. And if you have any questions, let me know. I will see you guys soon.